Let's talk about the treatment of the various forms of esophageal atresia. And we'll start with the simplest, and we'll go to the most complex. We talked already about the most simple form of esophageal atresia, which is the TEF. Now, the TEF is simply an abnormal communication between the back wall of the trachea and the esophagus. And that communication occurs about right here. Most of these are relatively simple to fix. And you can make a small incision in the baby's neck, which is the easiest way to get to most of these, and then simply dissect off or separate, gently pull apart the esophagus from the trachea, and when you see this little fistula, simply cut it in half. Part of it goes to the trachea side, part of it goes to the esophagus side. And the goal then is to have a suture line here, which fixed the trachea, and we have a suture line here, which fixed the esophagus, and just keep those two repair sites from crossing over each other so they don't recur. That is relatively easily fixed. The other types of esophageal atresia, which are the type C, and we're talking about type C, or we talked about a proximal TEF in the type C, are a little more difficult. This operation has to be done through the chest. We can't get to all this part of the esophagus through the neck. So we open up the baby's chest, then we just divide this distal tracheoesophageal fistula. Once we do that, we're then left with an esophagus like this and the blind pouch up here. Then we simply open up this esophagus up here and we sew them together with a series of sutures. What we're left with then is the two ends of the esophagus sewn together, connected to the stomach down here. And in this case, we had no TEF to worry about. There's nothing here. And on this side, we maybe had to fix the tracheoesophageal fistula and fix it on this side. Pretty easy to do on the scale of esophageal surgery. So let's talk about the most difficult form of esophageal atresia, and that is the long gap or the pure esophageal atresia. These babies have a bad problem, and that is there's a large distance between the two ends of the esophagus. As you can see here, this distance can be quite profound. It can be 3 or 4 or 5 centimeters, which in terms of length is huge for the surgeon to face. And in fact, this segment here can be very small, as we discussed. It can even be below the diaphragm. It can be a little nubbin of a millimeter or so in size. Well, how do we approach that? What can we do to grow this esophagus? And the truth is, we can grow that little nubbin to be a normal size esophagus, given enough time. And that's what I wanted to talk to you about. How is that done? But you need to understand a couple of concepts. One is the plumber concept. The plumber concept is how most surgeons would approach this. We have a problem. We have one end of a pipe, the upper end of the esophagus. We have another end of a pipe, the lower end of the esophagus, and they're really far apart. What can we do? Well, you don't see a plumber who's working on pipes pulling on the pipes trying to get them together. What you see is he puts something in between. And there's all kinds of things to do. You can move this one all the way up simply by pulling the stomach up. So you would end up with a short segment of esophagus, a big stomach, and all the stuff down here. But that leaves the stomach in the chest. Or you can bring something in the middle so that we could put in here some other conduit. We call those interpositions, something between the positions of the esophagus. But there's another technique to do this. And that was what was developed by Dr. John Folker in Minneapolis, now retired, who works only with us to develop this program. And that is to use the fact that the esophagus isn't a pipe. It's not a tube. It's an organ. It has blood flow, it has cells, it has development of this organ over time. And so what we can do instead of just putting something in between this long gap is grow the ends of the esophagus.